Good morning,
Okay.
everybody. Can you hear me okay?
Yeah, absolutely.
Okay, let's get started. Before we begin, I would like to acknowledge all the team members who took part in the care of the patient. They're shown on the slide. So our case is focused around a 46-year-old female who presented to our clinic with recent unintentional weight gain and elevated blood pressure. Her story begins though in 2014 when she underwent biochemical workup for complaints of new onset hypertension and weight gain. And during this time, she was found to have a abnormal 1 milligram dexamethasone suppression test and abnormal urinary cortisol levels consistent with Cushing's disease. This was followed up with a MRI in 2014, which is the first MRI here on the left. And at that time, she was found to have a 10 millimeter cellular lesion with a cystic appearance. There was no evidence for radiographic invasion of the cavernous sinus or the suprasellar space. So given that she had biochemical evidence for Cushing's and this pituitary lesion, she underwent transsphenoidal resection by the group at USF. And following the procedure, we didn't have her immediate post-operative cortisol values, but from February of 2015, she had a normal AM cortisol of 11.5, which was suggestive of remission. However, she did not have any post-operative hydrocortisone replacement therapy. And then her 3-month post-operative follow-up in 2015 was read as expected post-operative changes with no signs of residual adenoma. For the next 2 years, she underwent yearly surveillance with biochemical testing and MRI studies, and they were found to be normal. However, in March, she did have an abnormal dexamethasone suppression test, but this was followed with a normal urinary cortisol and MRI study. And then she continued to have surveillance until 2020. And at this time, she did have a return of this unintentional weight gain and return of her elevated blood pressure. And in November of 2020, she was found to have an elevated urinary cortisol and abnormal dexamethasone suppression test. Dr. McKenna, would you like to talk about how your team surveillances and works up these patients with Cushing's and evaluating for recurrent Cushing disease?
Sure. I think it's important to note that clinically, the physical exam is very important to really see if some of those Cushing symptoms are returning. And then for the actual biochemical, to establish the diagnosis of hypercortisolism, there's 2 out of 3 of different first-line tests need to be abnormal. That's the 1 milligram dexamethasone suppression test. The cortisol, if it's normal, should suppress below 1.8, and there needs to be appropriate dexamethasone levels. There also is the urinary free cortisol. Typically, we like to see it about 3 times the upper limit of normal to be considered significant for hypercortisolism. And then the salivary cortisol, typically we require 2 measurements. In this case, as you can see through the graph that you made, the 2017 started to be abnormal with the 1 milligram dexamethasone suppression test, and then increased to the 2021 at the end of the graph. And then again, the AM cortisol and ACTH are really just for reference, but showing that her levels were increasing over time. The last note on the slide is the IPSS suggestive of recurrent ipsilateral disease. So typically in a Cushing's workup, had she not had the history of the previous tumor resection, an IPSS can be done to determine if the Cushing is ectopic or pituitary or ACTH dependent Cushing's. But in her case, which we can go to this slide, she had this done as well at USF. It may have been done for lateralization. You know, we had her history. She had a history of it. She was having return of her symptoms. And just to briefly talk about IPSS, when this is done, essentially catheter is inserted into the jugular vein and ACTH is measured in the petrosal and peripheral venous plasma. And what we want to see is, or the patient is given CRH or DDAVP to try and stimulate the ACTH, and you want to see a peak within 10 to 12 minutes. In this case, the number is very obviously high at 1982, which suggests lateralization to the left. Dr. Sampson, anything else to add for her?
Yeah, I mean, I think that lateralization is really inaccurate with this procedure, partly because of venous drainage can be different among different patients. But in her case, what is really interesting is you can see that the entire right gland is suppressed because what you're measuring there is really just kind of the peripheral circulation of ACTH. And so everything here is on the left. So this is a beautiful example of true lateralization that confirms that perhaps small hypoenhancing area is residual tumor and causing the elevated ACTH. But in someone who has a history of a pituitary adenoma that has ACTH staining, probably unnecessary for the second surgery. I see Dr. Miller here too on the line.
Dr. Miller, do you have any comments about IPSS sampling?
Yes, sorry, I was called to a patient, so but I do apologize. I had to pop off where you talked about IPSS. Could you repeat the question?
I think it was just whether or not there's a comment, about the utility of lateralization in this procedure is probably not as high as we'd like it to be, but at least in this patient's case, it's very clear that her lesion is on the left.
No, I agree, and so and we see this at times. So I think it's one of those tests that's really helpful when it's positive. It doesn't necessarily, and also when you're not sure about a pituitary source versus a adrenal source, etc. It can be very helpful. But there are times when it doesn't lateralize as much and is as helpful as we'd like.
I think from the literature that I have known, I think the lateralization is about 70% accurate. Is that right?
That's in the range. Yeah, there are a couple different published things, but it's somewhere between 70 and 70, 65 and 80%. Depends on who you read. But I usually quote about 75%. Yeah. And it's interesting. I mean, in some people, it also depends. It's a bit anatomy dependent as well. What you find is that that the anatomy in this region, some people have really nice, well-developed sinuses on both sides, making placement of a catheter very easy. Other people have only one side is a good single channel. Another on the other side, it's a sort of a reedy, like a delta, with a whole bunch of small little channels. Then you've got to figure out where to place your catheter to maximize the collection, because if you go to one channel, you lose some of the stuff that's going around it, and then every once in a while you run into a patient who only drains to one side and doesn't have an IPSS on the other side. So in that patient, you're really not going to be able to get what you want, unless you're not going to be able to get what you want because you can't get anything from the one side. But so sometimes you end up playing with the catheters a little bit to try and get them in position. There have been once or twice where these things are both broken up little channels, and so I'll place the catheter sort of where the IPSS joins the jugular vein. And in all of these scenarios, you try to match up so where you think you're going to get about the same amount of effluent from the pituitary on either side. It takes a little bit of playing around, but you can oftentimes get it.
Thank you, everybody, for your comments. Very interesting with the lateralization aspect of this test. And moving on, when she presented to our clinic, her only pertinent ROS finding was weight gain unintentional greater than 20 pounds. She didn't have an apparent cushingoid appearance. Her past medical history was significant for type 2 diabetes, controlled with metformin, hypertension, controlled with lisinopril. She was on a topical corticosteroid for her eczema. She had 3 previous cesarean sections. Her family history was non-contributory, and her physical exam, including her neuro exam, was unremarkable. And then these are her most recent biochemical lab values. If Dr. McKenna, you would like to comment?
Yes, so her surgery had been delayed for a number of different personal factors. And as you can see, her dexamethasone suppression tests continued to be abnormal, and her cortisol and ACTH, even baseline values, continued to rise.
Thank you. Preoperative MRI studies were obtained. These are the T1 post-contrast. The left is the coronal. And if we look here in the inferior aspect of the sella on the left side, we can see that there's a very thin area of hypoenhancement with low signal intensity on the T1, and it appears to extend up towards the medial wall of the cavernous sinus. It has a similar appearance as the original cystic microadenoma that she had. Dr. Gupta, would you like to comment on this small area?
Yeah, I mean, I said that, unfortunately, I think the key to diagnosing an adenoma here, at least radiographically, is seeing a change over time. And so she had initial surgery, and she had then she had a little bit of a.
I have the changes here, if you want to.
Right. So as you can see, is this what's the temporal? Is it going from? Yeah. So I suppose that I don't have the timestamps, but so you do. So,
Yeah, 17 to 2022.
Correct. So as you can see that there isn't really any increase in the size of that area. And in fact, from 21 to 22, you would say that that area has actually shrunken and not necessarily increased in size. So I think radiographically it will be very challenging, or perhaps not appropriate to commit to that being an adenoma. Unfortunately, Cushing's is one of those diseases where the recurrent disease can be very small and be very symptomatic, and I think we can't conclude that what we are seeing here as the hypoenhancing area is not just scar and it is tumor. So this is I don't think imaging really. I mean, that's probably the area where you would go and explore.
Correct.
That's where you would likely to have recurrence around that area, and I think that's appropriate. But then calling that adenoma perhaps is an overreach.
And then on the sagittal, it's also hard to discern any evidence for recurrent adenoma as well. Would you agree?
Yeah, I agree. The good thing is that the cavernous sinus looks normal.
And and there's no compression into the suprasellar space.
Yeah, I mean, of course. Yeah,
yeah.
of course, there is no clear adenoma in the sella, and the cavernous sinus looks normal. So I think that's where you're going to go.
Dr. Almeida, do you have any comments on the imaging?
I mean, not that much. I mean, to me, like based on the appearances in the timeline, my impression was that we were going to have an adenoma on the left side. Based on that, no differences in nuances. The one thing, and to me, is that when we got, especially with a functioning tumor, either acro or Cushing's, that is close that relationship to the medial wall of the cavernous sinus, I think we always have to consider that there is a possibility that this will be strictly adherent to the medial wall. And in cases like this, from the get-go, my point of view nowadays is that we plan from the get-go, once again, like a surgery, to remove the medial wall of the cavernous sinus as a extension of the classic steps of pituitary surgery. So the surgical treatment plan for this patient, considering that this here as the medial wall that we were talking about, so adherent to that area, and the adenoma is likely here, is the area that we were going to remove to clean this to the best of our abilities, because once again, it's Cushing's, and Cushing's can recur even with basically no imaging, the MRI scan. So that's the plan, and we're going to see some of the steps of the procedure shortly.
And here's the T2. Again, we can see the same area of hypoenhancement in the inferior aspect of the cella, but hard to discern. And CT sinuses were obtained for operative planning. Is Dr. Donaldson or Dr. Alamu on the line if they would like to comment?
Yes. So the most important thing in these recurrent revision surgeries are careful endoscopy, looking at the pedicles for the nasoseptal flap. So, of course, perform operative endoscopy and review the scan to see if the pedicles for nasoseptal flap on either side are preserved for reconstruction, because, of course, there's a higher risk of a CSF leak in these intraoperatively in these revision cases. It's hard to always see that on the scan, but on endoscopy it's easier. The other thing to note on planning is there are residual posterior osmotic cells, including nodal cells, that partially obstruct access to the left cella, the left aspect of the cella and sphenoid sinus. So those will definitely have to be removed to provide full access to the cella.
Thank you. And then on the coronal, we can see the septations within the sphenoid sinus. And I had a question about in the radiology report here, it said that there was a right-sided concha bullosa. Is that the right-sided concha bullosa right here in the image?
Yes, it is. So
Okay.
that's another anatomical variant that we look at, which can limits the access to the skull base. So typically, I will remove those at the start of the case. It just makes the corridor for placing instruments in the endoscope much narrower.
Thank you. And then the sagittal view, we can see that there's incomplete immunization of the sphenoid sinus. So moving on. Just to recap, this is a 46-year-old female with a small area of hypoenhancement in the inferior aspect to the left side of the cella. She had biochemical and clinical findings suggestive of recurrent Cushing's disease. The plan for her, given her young age and the known adverse effects of hypercortisolism, we suggested a repeat surgical resection via an endoscopic endonasal transsphenoidal approach with the goal of disease control and obtaining tissue for diagnosis. The other options here are radiation therapy and medical management. Potential risks and complications are listed on the slide. And here's the operative video. Dr. Lim, would you like to comment on the ENT approach at the beginning?
Sure. So just infiltrating some local there. Then outfracturing the inferior turbinates, again, to improve that window. Now, this is that right-sided concha bullosa. So I'm removing that to improve access. There's also a concha bullosa, a small one on the left side, which I also removed. Now, she's had a prior approach. I am trying to preserve the residual pedicle of the nasal septal flap. So I will elevate that mucosa and displace it inferiorly. So in case she has a leak, we can use that. And then completing or expanding sphenoidotomy. Those are those residual partitions within the sphenoid sinus that I spoke about earlier. And now we're just drilling all those septations down to the skull base to provide full access.
And this is where Dr. Almeida comes in. Just drilling down, exposing the face of the sphenoid.
Yeah, you see that, yeah, exactly. You see that in this bone, the bone was really thick, so we had to drill kind of like a substantial amount of bone to get to the dura. And once you got to the dura in the sella, you can see that that is your landmark and your reference. And then from there, you can expand laterally, which is what we did. So this is the dura of the sella. And then in this case, we got to expose a bit more inferiorly and go inferior-lateral. Lateral so we can get interior wall of the cavernous sinus, and inferior lateral so we can get its most inferior part so we can have a safe opening corridor to open the sinus and get mobilization, mobilizing the medial wall away from the carotid. So basically just getting some hemostasis there, and we got to continue exposing. How far we're going to expose, you see that you got the clinoid segment of the carotid here. We're basically going to get at least to that point on the top, and then inferiorly, we're going to have to go even more inferiorly there. So just getting exposure on the right side too. And then here on the left, we got that that area of the anterior wall of the cavernous sinus exposed. And then the first thing we're going to do, can you stop the video for a second? I'll go back just a touch. Yeah. Go back a bit more. Okay, play. So you see, this is a very, very important step. So here, stop. No, don't play. You have here, this is the sella. And this here, everything that you see here, this is the anterior wall of the cavernous sinus, okay? Here in the top, we got the clinoid ICA, the clinoid carotid. So this is not cavernous sinus itself, but this here, this is all anterior wall of the cavernous sinus, okay? Then with the Doppler, we can map where the carotid is going to be located. Here, it's very easy to see. It's the most superficial part of the carotid, but the carotid goes and turns back as the horizontal segment, and it turns back as the paraclival segment like this, okay? So basically, we're going to map this area to identify, and this is going to be the area where there is no carotid, and that's why I'm going to open right there. So I'm not going to open the carotid, of course. I'm not going to open the sella because we actually want to open the wall of the cavernous sinus to go straight into the cavernous sinus in this case here. So let's see the video now, please, play. So usually would do that with a retractable knife. In this case, went with a scissor. And then after that initial cut, I gotta open that wall. I gotta use a feather blade. So there's gonna be blood, and I know that. So we gotta just deal with the venous blood. It's just if you know where you are, you're safe. So I know where the carotid is. I know that what is bleeding is venous. So we pack with hemostatic material, and then we got it under control. It's not a problem.
JP, let me ask a quick question right here.
Play pause.
JP, you can
Sure.
ask a quick question right here. So just for those who are less experienced, we know where the carotid is. We talked about the, get a good understanding of the actual anatomy. But what other techniques do you use? Just share with the less experienced surgeons, i.e. Doppler techniques to map the carotid.
Basically the Doppler. To me, like the Doppler is the one tool that you need. If we don't have a Doppler available for this case, I don't think we should be doing this case like this, because if you can't map the carotid with a Doppler, I don't think your navigation will replace that or will be enough to provide you safety to do that. So that Doppler, and then you're working as from lateral to medial or from medial to lateral if you prefer, following basically the sound of the carotid. Important to note that we're working on the left side. So your Doppler should be coming from the right nostril, just because of the angle that the Doppler will come, so you can map that safely. If you go with the left nostril on the left carotid, you may get into an angle that doesn't necessarily reflect the angle of the carotid. So remember that Doppler works better if you're working perpendicular to the vessel. So that's very, very important, okay? And then therefore with the Doppler, we can map it and then open that wall. The second point is the venous blood, it can bleed a lot. So you need to be comfortable with that maneuverability. And the other technique is the hemostatic pounder. If we don't have that hemostatic pounder, you're gonna have a hard time controlling that. The option is to use fibrin glue, so TCL. The other option is to use Surgicel, but Surgicel will take a lot of time to control that, especially because you're gonna be using in this type of case. When you open the wall, the first cut, it will bleed. You're not gonna be able to control if you place hemostatic pounder right there, right now. You need to open that wall more. And that's where this feather blade becomes very handy, because you need to have an opening that is at least of the size of the applicator of the hemostatic pounder. And then you can continue your surgery. So I think those are the most important steps for this initial part of the opening of the cavernous sinus. The second part is opening here, and then the next thing is how far you open. Can you stop the video? Okay, so here, once again, important anatomy. Here you got the carotid. So this is the clinoid segment of the carotid. This here on the top, we're gonna have the carotid clinoidal ligament. And here you're gonna see, as he plays the video, another ligament that we call the inferior paracellular ligament. And play the video, please. You see, that's the inferior paracellular that's being transected there. And then we're mobilizing. So the white thing that you see right here, that's the medial wall. And the red thing, well, that's the carotid. So hemostatic pounder irrigation, because we want to see what we do. It's very, very important to see what we're doing. If you don't see that properly, that's a problem. After we open the wall of the cavernous sinus, then we're going to go to the sala, right? So here, just the usual maneuvers, using a round knife to separate the capsule of the tumor. I'm sorry, the capsule of the normal pituitary gland from the dura mater, and then using the usual maneuvers, just creating the planes as needed. Using an angle knife to open that dura on the face of the sala, and then going all the way to connect that up to the medial wall of the cavernous sinus. And then when we get to the left point, we start to see tissue that is concerning for tumor, and we start resecting that tissue that its most medial aspect is inside the sala. So you see here, that's just separating the tumor. So this is here, this normal gland. And this is diaphragma on the top here, and tumor in the bottom part going up like this. So you see, we're trying to clean as much as we can from that side. And then there is a component that we can clean with use of pickups and the usual instruments. But then there is a tumor that is pretty adherent to the medial wall. So this is just the first cut in the base of the sala floor. And then you have to follow the floor of the sala all the way to the dorsal sala. So here immobilizing the wall from the carotid, so just creating that space that leads to more blood bleeding because you got opening different compartments of the cavernous sinus. Then you have to pack again, irrigate again. You have to be very patient with those maneuvers because it can take a bit of time. Then once that is separated, you see that now the medial wall is here and the carotid is here. So I'm pretty well dissected in that area. We can proceed with the cut. So that's the first cut, the inferior cut in this case. Then we're gonna have a second cut that is the one in the top that is gonna go using the reference of the carotid clinoidal ligament as the top. And you can see the yellowish tissue of the tumor that is coming from the medial wall. So there's tumor inside the medial wall in this case. And then we're going to be dissecting, and this is the inferior hypophyseal artery that we're ligating now. It is always in that location, which is just in front of the base of the posterior clinoid. And then as we remove that, you can see clearly, so the tumor in yellow, and then we're just proceeding with the resection of the last attachment of that medial wall. And you can see here now that medial wall being fully removed in a moment. So we're gonna get the last cut, and then here comes the wall. And that is all the medial wall, the cavernous sinus that is removed there. After that's completed, it's basically reviewing hemostasis. You can see the dorsum cell of the posterior clinoid here in this area. And then we can basically get the hemostasis with some gel foam and flow seal, and then we can get some of that gel foam to even cover the diaphragm a bit so we can decrease the chances of a leak. And then Dr. Olomo proceeded with the closure. Noma, any comments?
There was no CSF leak in this case, so there was no need to use a nasoseptal flap. However, to accelerate healing, and because of our postoperative course is unknown, so I just use a free mucosal graft to cover that, especially because the carotid was exposed there. So that sort of accelerates the healing and prevents the carotid from being exposed to sinus contents.
Thank you, Dr. Olomo.
Yeah, unfortunately, the final part of the reconstruction, the video recording was stopped before he performed that. Moving on, we have the pathology from Dr. Gentoff. If you're on the line, would you like to comment?
I don't know if Dr.
Here.
Gentoff is still here.
Yeah, I think. Let me see.
He was earlier.
Maybe he had to step out for a second.
He may have.
Chase, you wanna comment?
Yeah, so we don't have the histochemical staining, given that this case was performed this Tuesday for the hormonal markers like ACTH, prolactin, stuff like that. But here we do see that there's a clear separation of the anterior pituitary, normal anterior pituitary gland from the more homogeneous population of adenoma cells. And this is the normal anterior pituitary. We can see there's a mix of basophilic and eosinophilic cells. And then the adenoma has a more homogeneous composition of more basophilic cell type. And you can see this clear demarcation to the anterior pituitary. The diagnosis is still pending, given, like I mentioned, we don't have the histochemical staining done yet, but given that she had a previous pathology diagnosis of a corticotrophic adenoma, we can clinically say for the time being that this was confirmed recurrent Cushing's disease, corticotrophic adenoma. This is her preoperative MRI. We can again see that small area of hypoenhancement in the inferior left aspect of the sella. And then the postoperative, we don't see that same area anymore, and we just see some postoperative changes. This is the sagittal. For the sake of time, we'll keep moving forward. This is the T2. Again, we can see that area of hypoenhancement, and then here, that area of hypoenhancement is gone, and we don't see any residual evidence of residual adenoma. Her postoperative course, we did obtain on her cortisol and ACTH levels immediately following her surgery in the afternoon, and the cortisol was elevated at 33 and the plasma ACTH was elevated at 183. The following morning at 4 o'clock in the morning, she did get repeat cortisol AM and ACTH levels, which were both within the normal range. Dr. McKenna, would you like to comment on her cortisol and ACTH levels in the morning following her surgery?
So the cortisol is low, which is not unexpected after doing a Cushing's resection, but the concern would be for developing an adrenal crisis, given that we've taken away that ACTH stimuli that she's had for so long, which is the reason for supplementing her on the dexamethasone replacement therapy upon discharge.
Yeah,
And
this
she
is as good as it gets. This is awesome.
Dr. Sampson, does the reference values that they give here for like if this was her primary resection, it's like you consider a less than 5. Is it different for patients who undergo a secondary transsphenoidal resection, or is it still the same predictive?
The reference ranges from the lab just come from people walking around every day, and you do the cortisol. This is the post-op we see, any kind of substantial drop, and we would consider cortisols under 4 to be adrenal insufficiency, sometimes 3 now with newer assays, but yeah, this is a cure. This is awesome. Yeah.
And how long would you continue the replacement treatment? I mean, what's the typical time frame when things go back to normal?
Well, for Cushing's patients, the longer they're adrenal insufficient, the better, because this can take up to 6 to 12 months for them to resolve. We switched them from dexamethasone to more physiologic hydrocortisone after the first week. I just don't want them sick in the first week, so they have nausea, vomiting through that nicely rebuilt sinus. But at the end of the day, we withdraw them off hydrocortisone for repeat labs probably every 8 to 12 weeks, and you slowly see that ACTH and cortisol rise until you can take them off of the therapy.
Thank you, Dr. Sampson, for your comment.
Well, thank you very much. I mean, if one of our colleagues would like to add additional comments as well, I see here Dr. Fernando Haquin, I see Dr. Diego Gomez, I saw Dr. Vargas as well. Dr. Vargas, I see here as well. If any of our friends from Colombia would like to share any additional comments or pearls, we are all ears.
Excellent surgery. Both cases, different pituitary cases, and it's good to see that any case needs some different approaches just in this very small area of 1 centimeter. For me, the most difficult part is when the tumors are going into or pushing the cavernous sinus, and recognize sometimes the ligaments is important, because that's not recognizing those ligaments between carotid and cavernous sinus could be one reason of carotid rupture. So, and it happened to me, and learn from that the importance of that pushing when we are pushing and trying to take out the tumor. So thank you very much for the tips. The Doppler use very important. Sometimes it's not easy to recognize where is exactly the carotid with the Doppler, because Doppler sounds, and sometimes it's not, but I think that it's more technical issues. But for me, in the cases, the most important part was the carotid managed and the cavernous sinus. And you always teach many things, but leave that on practice is just cases and cases. So thank you very much.
Well, thank you, Gabriel. My pleasure. And I
JP,
see here.
JP,
I'm sorry, go ahead.
Good morning. Fernando.
Hi, Fernando.
Just the tips and tricks. One of the things that you said today, I think is very important. You can have the neuro navigator, and you know where the carotid is, but I think the Doppler is something that everybody should have in surgery for these cases, definitely. Because you think it's there, and definitely it's there. The neuro navigator is showing, but it's very important to have the Doppler. I think that's we usually
never had it because we never went into the cavernous sinus. But now that we're going into the cavernous sinus, we have to have that. That's one of the tips I learned today. Thank you.
No, my pleasure. And good to see you. Good to see you, Gabriel, as well. And I saw Diego. And well, thank you for the comments, and thanks everybody for joining us. Dr. Sanson, Dr. Chang, any final words, Dr. Olomo? If not, I think we're gonna finish here, and I will invite everybody for next Monday. In fact, even today, Dr. Q is seated right next to me. He's about to start a presentation here for the World Federation of Neurological Surgery as well. And some of the other team members at Mayo will be presenting. So the link, one of the team members can share with the group, maybe Dr. Navarro. And on Monday, we have Dr. Rushna Ali, who is a new team member at Mayo enterprise level, but based in Rochester, who's going to be giving us a talk on the surgical management of cancer-related pain. Everybody's welcome to join us on Monday, starting at 6:45 to 8 a.m. Thanks, everybody. Have a very good weekend, and hope to see you all very soon. Bye-bye.
Obrigado.
Bye-bye.